what are things that we can think of that we can offer? Obviously, there's medication. In terms of other things, there's behavioral health, referrals. What can we offer maybe that the patient can do on their own?
Physical, psychological, spiritual, and social. So that can mean a lot of different things. Physical, the sleep, the movement, the exercise, the nutrition, to be able to get those chemicals in to make the good chemicals in our body. The psychological part of doing things that are fun, enjoyable, things that make you happy, recreation, things that help your brain grow, that's learning or evolving. And then the social part of it, your environment, who are you surrounding yourself with? Who are the people in your life? Because that's huge. That reflects on you. And then not only the environment, but the relationships, and then even what they do in their roles, whether it's a student or they're working or anything else. And then the spiritual, that means different things for different people. But what's similar amongst all things with spiritual is there's something bigger or greater than the person. So ways to engage in that, read, learn about it, worship, and then living a life of purpose. Like, what is your service to others? I think that's why we're at this table and talking about what we're talking about. It's our passion, it's our purpose. So doing things that are spiritual in nature. So I believe that all four of those things have to be addressed: physical, psychological, spiritual, and social. And it doesn't, I think bringing this to a DEI, I think there's different emphasis on one of those, four maybe, but they all have to be there. Kind of like if it's a medical condition, you have to treat it broadly.
Right. Well, that's awesome. I think you guys have touched on some amazing things that you can do on your own, and with strong evidence and benefits, and in addition to medication, in addition to specific behavioral health. What
can I?
sources?
Sorry to interrupt. Can I touch on one thing that I just thought this came into my head when you were talking about physical, and when we talk about disparities, I think this is a great example of disparities. Physical, children need to run. They need to jump, run, kick a ball, all the things. Okay, like especially if they've been in school all day long. Well, what if I've got a kiddo that lives in a neighborhood that is not safe? And I've asked that before to parents. I'll say, is it safe where you live? Can your child go outside? Mm-hmm. And I think that when we talk about disparities, like that's another thing to think about. You take it for granted. I take it for granted sometimes. This kiddo lives in a safe place. Maybe he or she doesn't. And how can I ask mom to have the kiddo go outside in the backyard if it's not a safe place?
Sure.
So then if I get the sense, or she says, well, it's not really safe where we live. Okay, well, do you guys have stairs? Yeah, we got stairs. Okay, make it, let's go run up and down the stairs. Let's put some music on. Let's dance. Some way to get physical, right? Mm-hmm. Or the spiritual aspect, right? And like you said, it means something different to everybody. There's some pretty good evidence and some pretty good studies out there. Children need nature. They need to go to a safe outdoor space, whether it's a park, whether it's, the belt line, a greenway, whatever, to hear the birds, to see the squirrels running around.
Just to get some sun on you.
Exactly.
Sun.
Vitamin D.
And get a little
That's right.
vitamin D. Exactly. So sorry to interrupt, but I thought that was, it just came into my head about the physical, especially when we talk about disparities.
Mm-hmm.
Where does this kiddo live?
Right.
Is it safe?
Well, and that's true. I think that's really important, because even the economic aspect, we could be saying, they need to have more fruits and vegetables. Well, we've got ramen noodles or ramen noodles.
Because that's all we can afford, because it was 10 for 10 at Kroger.
Right.
Exactly.
So there are definitely some hurdles.
Mm-hmm. Mm-hmm.
That's all very useful, very important, and some of the things that we want to touch on in terms of the disparities and kind of why they exist and what types of things contribute to that. And that's definitely important. And like you mentioned, even financial, so there are things that we want to do, things that we recommend, but can you literally, are you able to do it? You may not be able to afford it.
Right.
And that's a potential issue as well. So in terms of disparities, money, safety, food security, obviously there is a wide variety of things. What do you think are some of the things that people can do in terms of when they come see you? I mean, you have 20 minutes, maybe you have a half an hour. how do you best touch on those things to find out what those issues may be that may be limiting someone who wants help but just doesn't know how to go about getting it?
I mean, I think the way we begin every kind of assessment is doing the whole person, like you've talked about before, and looking at social determinants of health. Where do they stand with everything? We're talking about encouraging them to sleep 7 to 8 hours, but their environment is toxic. So doing that inventory and then looking at resources after that. I mean, it's great that we're in an organization where we have social services that are a wealth of information and knowledge, and that we can connect them with local community support, whether it's food bank, whether it's community mental health, a lot of different resources out there. But we're blessed to have that. And I won't say that everybody else does. But just having a good assessment, a needs assessment, and looking at social determinants of health, and just trying to match and connect those dots with resources and access. And it's amazing how much I can learn from the people that are in my office. They teach me so much about resources. And then the community effort of that. So volunteering at a food bank and then getting together with somebody else, like, my child won't eat this, I won't eat this, let's swap. So even looking at it from a collaborative effort.
Awesome. I think you're so right about that, and especially if we have some folks that are kind of on the edge in terms of, culturally they don't feel like they belong in a community or whatever. If they have a way, what does everybody want? Everybody. It's a basic human need. We want to feel connected. We want to feel like we belong, right? So if you can say, well, do you have, it's getting creative with things, right? It's prioritizing what is the most important thing that you need. Well, have you thought about, is there a church near you that, oh, well, I know there's one and I know they have a Spanish mass, or whatever. Mm-hmm. That sounds like that'd be a great idea. Maybe you'd meet some people there. It's sometimes, I think, especially parents can feel so overwhelmed when there's just so much going on. So I feel like a lot of times my job, it's almost like being an air traffic controller, or I don't know if that's quite the right analogy, but trying to prioritize what is going to give you something short term that's going to that'll help build maybe some confidence or give you some hope. I always feel like I need to give hope, especially when we talk about mental health issues and mental illness. There must always be hope, right? And so I feel like I've got to prioritize and figure out what can we do today, Mom, or in the next week, and start with little bitty steps, right? How do you eat an elephant? One bite at a time, And so I think it's just so important, like what you're talking about is figuring out what are those resources? What are the realistic resources, right? Because I can give you all the resources in the world, but if you don't even have a car to get there,
True. Or
maybe you don't have reliable internet, or your phone got cut off, what can I do? What are your neighbors like? Well, there's a really nice old lady that lives a couple doors down. She doesn't have any kids and her grandkids don't visit too often. Wonder if she might be nice to get to know. Just to have that connection, and then the kids have some multi-generational stuff. I just feel like it's always doing these layers of stuff, if that makes sense,
Well, and I think what you were saying too about hope is really important, because that is kind of the one thing to go pretty quick, especially when you just feel like you've been beaten down. But I like to see people through to provide the hope, but also see them through a lens of resilience. Sometimes we have to believe that they can overcome and adapt before they can believe it themselves. And so just kind of holding on to that I've got us for now. I'll keep throwing resources until something sticks. And then it will. And people are resilient. They will overcome. It's just not always on the timeline we want or at ease. I kind of joke around with people saying, I wish there was like a drive-through window for mental health, right? Just drive up, like everything else is so fast. Right. You drive up, you get what you need, you say what you want, and then you drive off and everything's nice. But it's a process. Yeah. And I think if you have that hope and that connection, that someone is aligned with you and is willing to go on that journey with you, that's really valuable.
Thank you. Those are great comments and I think very important and useful. I do want to throw out here something that is not uncommon to me. You have an older gentleman who works 15 hours a day and is very stoic and says everything's fine, but his PHQ is 23. And you can tell that there's a stigma. You can tell bringing up the conversation is not going to start well. Hopefully it ends well, but it's not going to start well. How do you approach that? How do you approach this? Everything's okay. This thing you're telling me about, that's just a number. But you sense that there's more. How do you get onto that veil?
So I guess I'm giving a little bit of a different perspective because most of my experience is in like the acute inpatient setting, because we don't do outpatient really until next year.
And we can't wait for that.
That's right. That's gonna be fun. But we do have the luxury of seeing the patients like sequentially one day, and then kind of building that rapport over time, but also kind of like addressing the elephant in the room, so to speak. Like, I understand that, maybe mental health wasn't as much of a priority of people of your generation, and especially for men. Again, they grow up with this idea that showing emotions or having feelings is a sign of weakness, that sort of thing. And then just kind of talking with them about it and just letting them know that, hey, it's okay. And a lot of things that I kind of like to say, it's like it took you a while to kind of get the way you are and think the way you are. So it's probably going to take a while to kind of change those things as well. And they're usually pretty receptive to that.
Yeah.
That's a good one.
That's a really good one. I like that. That's excellent.
And I think that, I guess we're going on an elephant theme, I think that is important. In fact, I usually start therapy with, have you ever had therapy before? And when people say no, I kind of use my age because I think I'm the older gentleman now. But I say, I don't know about you, but I was raised, don't talk to strangers and don't share personal information with strangers, right? And so here you are in front of this counselor, this therapist, and I'm asking you questions that are hard to answer. And it may be really uncomfortable, but let's go in any direction we need to go in. And I know some things are hard to talk about, and we'll just go at the pace in which you're comfortable. And then I also put out there that I may not be a good fit, because sometimes who we're talking to can make a big difference. And I tell people that getting a therapist is like trying on shoes. Sometimes they fit pretty good. Sometimes they don't. Sometimes you wear them for a while and then you get a new pair, right? And I think that accepting that as a therapist is important, and then empowering our patients, our individuals, to make those changes, to find that person or that place that they do feel a little bit more comfortable. Addressing that is important.
Yeah, I find that it can be tricky sometimes getting them to that point where they'll go to a therapist. There are some people that there are multiple referrals and they just haven't been, and they don't pick up the phone, they don't call back, and it's really tricky. Even getting to the point of starting medication sometimes takes a lot. It's not seen as a problem, or it's just that stigma, like people are going to call me crazy, or it's tough to go through. It is something that's attached, and I think we need to. I know we all know it, but we need to. Systematically get rid of that stigma. It's just like you said, it's asthma, it's diabetes, it's a headache. You got to do something to take care of it. And I don't know what it is, but that's something that's really important. We need to continue to work on.
Do you think, Dr. Vicknair, I'd love to hear because I try to do a lot of motivational interviewing techniques, and it seems like even in a grown-up like that, much like an adolescent that is like, I'm not going to therapy. I had one the other day that had autism, and he was like, I'm not doing it. And I said, tell me what you think. Tell me what the deal is. What do you know about therapy? And then, asking those open-ended questions, because what I did with this kiddo was I said, what do you think's the worst that would happen if you went to therapy? What do you think's the worst thing? Very high-functioning autism kid. What do you think's the worst thing that would happen if you went? It wouldn't work. So, well, that's a good point. It might not. You're right. what do you think's the best thing that might happen if you went? Gets this scowl on his face, and then he kind of smiles a little bit, and he goes, I guess I'd get more social. I said, well, seems like this is a winner-winner chicken dinner. I mean, and he started laughing. I said, dude, it seems like you got nothing to lose, But I feel like it seems like with an adult like that, because I can imagine, right? I don't do adults. But I can imagine, right? Just the reticence. Well, I'm fine. Those two words are like the worst words. The worst phrase in the English language is, I'm fine. Mm-hmm. No, you're actually not. Yeah. So... But I don't know, what are your thoughts on doing, like, for a physician to be doing some brief, motivational interviewing type stuff and, that kind of thing?
Well, I know this psychiatrist that's well-versed in motivational interviewing because we've done some great training on it.
There you go.
Yes. Well, we do use it quite a bit. Just kind of assessing where they are. Meeting them where they are is really important because, you can lead someone somewhere, but they're going to do what they're going to do. Mm-hmm. And ultimately, you don't want to, I don't want to put this. You want to work, but don't work harder than the other person is willing to work. Very important. You'll just burn yourself.
Yeah, and I think when you're saying meet them where they are, that's the stages of change, right? So some people are pre-contemplative. They're like, well, yeah, I'm not really interested, whether it's smoking or getting themselves healthier mentally. And then could go into contemplation. Like, I'm thinking about it. Like, I may just see if this doctor is going to read this questionnaire that would indicate that I have anxiety or depression. And then there's preparation. This is where I might want to hear from you, or you can educate me on what my options are, and I may get back to you on what I might be interested in doing and when. Maybe I'll see that therapist. Maybe I'll try that medication. And then there's action, and that's where the person's actively engaging. It doesn't mean that the therapy or the treatment's working yet, but at least they're going through the motions with it. And then once they do it over a period of time, hopefully they get to the point of maintenance and what they're doing is working and they maintain it. Now, people can relapse and they can bounce back and forth, but there's a lot to learn from relapse too, because that means you're identifying what wasn't working, what else did we not pay attention to, what were those things that kind of set this into motion in trying new treatments. So meeting them where they are is really important, especially with those stages of change.
And that last step is called relapse, not lapse, because, we're expecting people to kind of fall off a little bit. It's part of the process.
It's like a guide and support framework almost is the way I sort of think of it. And I think for me as a physician, and I would think this would speak to other physicians, one of the reasons we all go into this profession is to fix. We fix people. Right? I'm here to fix you. I fix people. And when you are talking about these kind of issues and motivational interviewing, a lot of ways it's kind of counterintuitive, or for me it is. It's kind of meeting them where they are, not really saying, well, what about this, and this? It's saying, it's kind of taking that step back, like what you were saying, and letting them work through that. And you're kind of the guide and the support there throughout. So I feel like it's not always the most intuitive thing for me, and I've had to work really hard to learn how to be better at motivational interviewing because it's such a great tool. Mm-hmm. I mean, and the fact, I know, you guys have it down, and it's been something for me to really learn and work at. So I want to, I guess, give some encouragement to physicians because I think sometimes our frame of mind is I got to fix immediately, right?
Yeah. And it can be difficult because you know that there's something there, but they have to give you a little bit. They have to bend a little bit, work with you a little bit, because and going back to the stages, if they're totally not ready, is not much you can do. But I think it's very important that you be persistent and there's some people you have to see frequently, make that relationship as strong as it can be, and just continue to work with them. I did want also to touch on, I know in terms of when people do have issues, and if it's emergent, we have 988, that's the suicide crisis hotline. What other things are available for adults and kids? Kids are always on their phone. What can they do? Who can they call? Any other resources that we have?
So I know for those locally in this area, we have the Avita Crisis Center that they can always walk into. There's someone there 24/7. We have all the emergency departments that Northeast Georgia has available, and all the different counties that we have: Barrow, Habersham, Toccoa here, Brazelton. So there's quite a few different locations that one can seek help if they need it urgently.
And you were bringing up great points, and the 988 is national. There's the Georgia Crisis Access Line as well, and that kind of goes to something a little bit more local. And you some great points.
Yeah,
too.
with GCAL. So this is with GCAL. So Georgia Crisis Access Line. If you have a in-state Georgia area code, then you will get, you have to have an in-state local Georgia area code with GCAL, or else it's gonna put you over to the national. So if you call national 988, not a problem. Most of the time you're gonna get probably somebody within the state, but if you have an out-of-state phone that you call on, you're definitely gonna get likely more national, not necessarily local. So that was something I just recently learned. So that was just sort of an important delineation, but either one of those, yeah. And that's for, adolescents can call that too. And I've got some really great info I shared with you from the Department of Behavioral Health and Developmental Disabilities, the Georgia Department. They've got this nice little teenager flip book, and it goes through all kinds of things about suicide, self-injury, eating disorders, anxiety, depression, all that. And I think, again, it's just getting that word out that, you can call 988 is like the mental health of 911, mental crisis as opposed to 911, where we've got somebody trained on the other end of the line. Because I've heard horror stories, and I'm sure you have, and we've all heard or seen horror stories when it was somebody maybe not trained in a crisis situation, and it doesn't usually go very well, unfortunately.
And we're fortunate, too, in Gainesville to have a grant that funded a mental health professional going out with the police officers when they knew it could be a domestic dispute or there could be mental illness involved, where that clinician can do some de-escalation and help route to not necessarily jail all the time, but maybe even psychiatric treatment. Our jails are full of people with mental illness as opposed to getting the probably more proper or better health. So I think prevention before crisis is really critical.
And again, when you talk about marginalized populations, 70% of kids in the juvenile justice system have a diagnosable mental health condition. 70%. So more than 2 out of 3, 7 out of 10. So it's great that we have that, because I know not all counties have that, and it's amazing, because then you've got somebody that can de-escalate and talk them down a little bit.
That's really important. Thanks for sharing all those resources. I think we've covered a lot, and I think I want to give everyone a chance to kind of touch on something that you didn't get a chance to touch on in regards to mental health, in regards to disparities. If there's anything that you just want to make sure that we let people know in our local medical community here.
You're looking at me.
Well,
Do I need to just
Oh, gosh, I know.
You're just the closest.
I guess I'll kind of start where I kind of left off. I really think prevention is critical. I think taking a risk, opening up, especially to a healthcare provider, it can be the beginning, especially a family medicine doc, because that's, hopefully we're all going at least once a year. And being honest about what a person's experiencing. And then when you get the referrals, to try it out. You don't have to stick with it, whether it's therapy or medication. You can try it out and see how it goes, and being patient with that process. But doing at least the basics of taking care of physical health, psychological health, social health, and spiritual health.
Awesome.
It's awesome. It's a hard act to follow right there.
Thanks.
I would say, as a pediatrician, and I'm going to be training family medicine physicians, but they're going to be seeing peds. So I think for me, it is about normalizing mental health, that mental health is health. And I start talking about it, even, again, from that first visit as a newborn, Mom, how you doing? And I have them do the postpartum, screening, starting to talk about it early on when she brings in the 3-year-old that's pitching fits, right? Let's talk about that a little bit. What are you doing with that? And I feel like for me as a pediatrician, it is normalizing children's mental health and emotional health and how it all ties in with their environment, et cetera. And so it's talking about it at every visit. How are you holding up with, man, that was a long hospitalization you had with them, and how did that work for you? And and she's like, this child now is having all this regression. Well, you just got out of the hospital, and let's talk about development. So always going at it from a developmental stage and figuring out what does this family need at this developmental stage of this child, because it changes, right? And knowing what's normal and what's not normal, and starting to recognize that and doing the appropriate screenings and getting them where they need to be.
Makes sense. Awesome.
Wow, Dr. Vicknair, Dr. Contrucci, I thought you both really hit some pretty important points about the prevention, also about normalizing it with the patients. I guess the only thing I can really add is maybe for physicians or physicians in training to maybe just practice normalizing it when you're talking with your own patients and screening for those things. And if it's something that you're not personally comfortable with, I mean, for one, I always tell people, as doctors, we get paid to be nosy. So
that's great.
There's that, but also practicing will help you become more comfortable asking those sort of things. Mm-hmm. So that's all I wanted to add, really.
Yeah, that's important. I mean, that's what we're here for, right? And you have to ask the question, and then you have to trust the patient, and then you have to work with them. Mm-hmm. And I think if we don't ask the question, we're doing them a disservice. And then if we don't act on the information, we're doing them a disservice. So I think it's important to really work on those things to really get that strong relationship. Mm-hmm. I think that's that doctor-patient relationship. When they get that trust, I think that goes a long way. And I think that will help to get rid of stigma. I think that will help to overcome, some of the issues related to that. And covering all the bases, looking for those social determinants that may be a factor affecting, their ability to take care of themselves, or take care of issues, take care of their kids, and those types of things. So, paying attention to all those factors are really important as well. But I think that's about all the time we have today. I want to thank all of you. It was a great discussion. This was easy. You guys just ran with it. I was like sitting back. This is awesome. Have you folks here all the time.
Thanks for having us.
So thanks again. And if you guys want to come back anytime,
let's continue the conversation.
Glad to have you. So we're going to wrap up today. Today the DEI podcast. Today we focused on mental health and mental health disparities, and hopefully we all got some great information. And please remember there is CME available, and there's a few questions at the end of this podcast. Thank you.